Perfect. So good afternoon. This is our webinar with Rosie Cardale about debunking diastasis. As before, please keep your microphones off. This is being recorded and will be shared out. You're welcome to keep your cameras off too. If you do have any questions throughout the session, please raise your hand. We'll try and make it as interactive as possible, but there will be an opportunity to ask questions at the end. And if you don't have a microphone or anything, you can just pop it in the chat and we'll try and answer it when there's a natural break. So I'll let Rosie introduce herself.
Hello, and thank you for joining this webinar today. I'm going to start by showing my screen and hopefully it works. It's always hard to know whether I quite like Teams, but it's always I'm sort of more used to using Zoom. Anyway, let's see if this does it. Can you see that, Lily?
Yep, perfect.
So thank you for joining today. Some of you may have come across me with some previous teaching that I've done for the BNSSG Training Hub. But today's topic is all on diastasis, which is hopefully something that you're all familiar with, but this will allow you to become a little bit more up to speed with what it is, why it happens, and some of the sort of research and current research on how you can help the women that you might be seeing who are presenting with it. It isn't just a postnatal problem, so there is can be prevalent and happen to men as well. So, but we're going to really focus on the postnatal population today. So by the end of the session, you should have a better understanding of what it is, how to apply it to the patients that you're seeing, or just to start conversations or give them and empower them with a little bit more knowledge. Challenge your thinking about it. It's a topic that has changed a lot over the last few years, and it will continue to change. And I find that sometimes quite exciting when it comes to these areas of health that is ever growing and ever changing. So what you learn today hopefully will empower you and educate you for your next few months and years, but it may change again within the next few years as more research comes out about it. Please feel free to pop any questions into the chat. Lily will then pass them on to me. So I don't mind being interrupted in the moment if you have a question, but there will also be some time at the end to also ask some questions too. So who am I? So I'm Rosie. I'm a pelvic health physiotherapist. The way I describe that, if you're not sure, is that I'm interested in anything almost from the ribs down to the tops of the thighs and all of the muscles, the functions, and the joints and systems within that area. So your abdominal wall is a huge part of that area, and how it functions and how it works and its sort of support to us is something that we often overlook with, I definitely know I didn't get any teaching about the abdominal wall in my standard physiotherapy degree. And it's only since I've specialised in this area of health where I've really become a lot more familiar and have a lot more knowledge about how important it is for us. And we'll definitely go into some of that today. I have previously been in the NHS. I'm not currently working in the NHS. I work full-time private in a busy clinic in Bristol. And my real passion is sort of helping women to understand their bodies and really be confident with movement and exercise. And we'll look at why that's important, particularly for the female population. But I sort of marry the two sides of physiotherapy where you're looking at pelvic health in its sort of the dysfunction that we may get in that area, and marrying that with movement, exercise, function, and making sure that the two sides are being looked at in full. So what is a diastasis? So you may have heard or seen other terms that it's used to describe, and it's all describing exactly the same phenomenon or presentation. So it can be known as rectus abdominis diastasis or RAD, abdominal gapping, mum-tum, which I hate, the use of that, rectus diastasis abdominis, so exactly the same as the one above, but just put in a different order. Divarification, abdominal separation, and diastasis. So they're all describing exactly the same thing, which adds to some of the confusion about what this is and is it the same thing as all of those different terms, which it is. So what is it? It's a widening and a lengthening of the linea alba. Now we'll go through what this linea alba is, but in its most basic term, it's the white tendon-like tissue that attaches to your base of your sternum and goes all the way down to your pubic bone. And the muscles feed into that tissue. So it's almost like where muscles would normally attach to a tendon and then attach to a bone. We don't have a central bone in our abdomen. So it almost replaces the sort of bony structure that those core muscles would normally have attached to. But a bone through the middle of our abdomen wouldn't be very good at giving us as much movement as we need in our day-to-day lives. So we have this amazing soft structure. It can also be a reduction in the integrity and the ability to create tension within that linea alba. So you actually may not get a widening and a lengthening of the tissue, but you might get a reduction in its ability to create tension, which is really important for how muscles and particularly this abdominal wall works. It's a really natural process that happens in all pregnancies, and we'll look at the stats in a minute, but it will happen in 100% of pregnancies within that third trimester. And it happens because that baby is growing, but what that baby's growth is doing is it's naturally increasing intra-abdominal pressure within our abdomen. And so it's not just pregnancy that when it can happen. It can, as I said, happen in men. It can happen in people that have ascites within the abdomen. It can happen when there's a big increase for whatever reason in intra-abdominal pressure within the abdomen. So it happens in 100% of pregnant women in that third trimester. And yeah, it is that sort of increase in intra-abdominal pressure. It's definitely an area that is sort of lacking in research at the moment. And research is definitely changing. So this is a relatively new 2021 is when they found out that it is happening in 100% of pregnant women. And yeah, so I always think, as I said earlier, that areas where there's less research, shall we say, is actually quite an exciting place to be, because we always then have to keep slightly on top of the research that's then coming out, and it will challenge our sort of narrative and our thinking process and patterns with all of it. Interestingly, because of that, or part of the sort of presentation of that, I've seen the same woman 3 times over probably the course of 5 to 6 years. She's had 3 babies, and my approach to helping her with her diastasis presentation has changed after in each postnatal section or postnatal recovery. So yeah, and that's in a relatively short space of time. So and the things that have changed, which we'll go through later in this presentation, are relatively small, but they've made massive changes to then her recovery each time. So yeah, it's just quite interesting. It's also when we experience diastasis within our body, it can create implications and negative body image implications. It can reduce our sort of quality of life, and most importantly, it can really reduce that sort of confidence with how that woman is able to exercise. And we know that for our lifetime as women, we really need to feel confident with exercising. Exercise has so many benefits to us in terms of our muscle mass, our bone density, our mental health. And if something like this presentation actually reduces that woman's ability to confidently move for a period of time, you know, a number of years, then it's going to be much harder for her to then overcome that barrier and get back into the exercise that is so beneficial for her. I always think that, you know, in other areas of rehab within physiotherapy, we are very good at knowing exactly how to rehab a hip after surgery or after a fall. We're very good at knowing how to rehab a shoulder. We're often very good at knowing how to rehab our backs. But why don't we know how to rehab or how to get the best outcome from changes to our abdominal wall? So yeah, it's really important that we are helping women to feel empowered to know how to approach this part of their presentation. So interestingly, we don't really know what the risk factors for developing diastasis are. They potentially haven't been all that well studied, but if they have been, then it's just currently a little bit unknown. But we can pretty much say that pregnancy increases our risk factor for diastasis, increased parity, so the number of babies in that pregnancy, multiple pregnancies, so more of them. There's the potential, and there's quite a good amount of research now on genetic predisposition to it. So looking at, and we'll look at this study in a bit more depth a little bit later, but looking at actually collagen makeup of the tissue, and if we're missing two particular types of collagen, which is very hard to know if you do, and it would only be through biopsy or surgery to know that in particularly. But that's quite a big part of it, and that seems to be a genetic predisposition to missing those collagen factors. But looking at your maternal line, so your mother, your grandmother, what does their skin and tissue present like? Have they potentially developed diastasis in their pregnancies? The trouble with looking back at women who are a generation ahead of us is that even though we're still in an area where the research isn't as good as it could be, they possibly didn't then apply what we currently now know to their recovery. So I would sort of argue, if a woman who's just had a baby is in front of you and you say, oh, do you know if your mum had a diastasis after her pregnancy? She almost definitely, the mother, won't have had been necessarily proactive at trying to resolve it or get the best outcome for it. So I always take that with a little bit of a pinch of salt, but it's an interesting thing. There's a sort of query as to whether IVF could increase your chance of developing diastasis, possibly because of the sort of big fluctuations in hormones, more so than if the pregnancy was a natural conception. Increased weight, and particularly increased abdominal weight, can just create that increased stretch within that tissue. Abdominal surgeries, and because of the disruption potentially to that abdominal wall and how those muscles then want to work, and high levels of sort of abdominal exercise load, any strain through that abdominal wall, and increases in higher sort of intra-abdominal pressure from more that aren't pregnancy related. How can we reduce the prevalence of it in pregnancy? Well, actually we can't. To go back to the collagen fact, there was a study completed by a team of plastic surgeons in women that were having abdominoplasty operations for hernia repairs, and they found that actually women who lacked collagen type 1 and 3 were more at risk of developing a diastasis than those who had higher levels of it. So that's the sort of genetic and potentially lacking in collagen predisposition to developing diastasis. And I would say that it's likely that women that are lacking type 1 and type 3 collagen have a higher risk potentially of presenting with hypermobility. So that would definitely be another factor for thinking about if somebody is at high risk of having this. So we can't reduce it in pregnancy. It is a naturally occurring thing. And there's no sort of set of exercises that anyone can do to say, if you do these, then your chance of developing it is better. But we do know that from a sort of postnatal recovery point of view, the better that woman is able to connect to her core system, which isn't just the abdominal wall, it's also her diaphragm, her pelvic floor, and some of her back muscles, the better she's then going to be able to rehabilitate that area, or the more connected she'll be to then start that rehabilitation journey. But yeah, you can't prevent it in pregnancy, and you can't do anything in a pregnancy to reduce the presentation of it postnatally. Some of the things that I would consider during pregnancy, or when we know that there's a higher chance of that wall being challenged, are managing constipation. So if we're constipated, then you're going to want to be straining to help you evacuate that bowel motion, and that will then increase a sort of downward increase that pressure onto that abdominal wall, and that over time could just tire the tissue or be an unnecessary increase in exposure to high intra-abdominal pressure activities. Really thinking about their breathing, so really thinking about sort of managing breathing techniques, particularly if the woman is very sporty and is maybe lifting quite heavy, then making sure that when they're lifting, they're able to employ good breathing techniques or maintain conversation whilst they're lifting. And staying strong. So a lot of women that I see in clinic are very fearful of this doming, which we'll go through, and you can see the image on the screen is a presentation of what we call doming. We'll go through that in a little bit more depth in a minute, but it's not to necessarily avoid this. So there's a lot of talk at the moment about how doming is bad, and when you see it, then that exercise should be stopped or regressed. But actually, women that are maybe in a second or third pregnancy, so the stretch to the abdomen has already happened, or they've got that reduction in sort of natural connective tissue, and they've got softer tissue within their whole body, but their abdominal wall as well, they might be doing something really simple that's creating this doming response. Actually, it's not the activity that's unsafe, it's actually the presentation of what's happening in that dome. And doming is really just a reflection of that wall having thinned, and therefore that sort of slight weakening of the linear albus structure, but it doesn't mean that it is really weak necessarily. I always say that when anywhere in our body, and we know from physics as well, that pressure will always want to take or leak out through the path of least resistance. So when the pressure is rising in our abdomen, which can happen with movement, can happen with straining, can happen with loads of activities, then that pressure will sort of say, okay, well, I'm rising, where can I go to sort of until I meet resistance? And if that linear albit is soft, and is soft because of a hormonal imbalance or because it's had this stretch already, then that pressure is just trying to push against that softer wall. So always think of it as that sort of path of least resistance. We probably don't want to see doming happening over a prolonged period of time. So it's something to not fear if it's happening on the odd occasion. But it can be a really useful tool, particularly in the postnatal population, to sort of allow us to see where that wall is starting to struggle. And we know with muscle strengthening principles that the only way to get a muscle stronger is actually to sort of get it to a point of fatigue or a point of challenge, and then the muscle will say, okay, this is challenging for me, I want to do this better, so I'm going to have to start getting stronger to cope with what I'm being exposed to. So I, in clinic, use doming as actually a tool to say, okay, this is probably a nice thing to see. We're knowing that your tissue is being challenged. Why don't we then use this over the next few weeks and months to build your progression with a certain exercise? And there's different ways that you can also manage doming. So sometimes when I'm looking at an abdomen that's doming, I might see can we influence that doming? So can we allow them to get control through that abdominal wall with thinking about the rest of that core cylinder? So thinking about their breathing patterns, their pelvic floor engagement, and maybe a sort of core connection and core contraction. The other ways that doming might be being spoken about is coning. I sometimes call it tenting, and sometimes I explain it to women if they're sort of not sure what they're seeing, as like a little Toblerone that comes out through their abdominal wall. And you can see in that image that it's happening quite nicely all the way along from almost breastbone down to pubic bone, but maybe it's a little bit more pronounced up above the belly button, and we'll go through why that is in terms of the anatomy in a minute. So let's have a little look at the anatomy of the abdominal wall. It's very complex, and there are multiple layers that contribute to the wall, and then this linea alba in the middle. So we've got different thicknesses at different levels. The thinnest part of that linea alba, so the central part through the middle of the abdomen, is the thinnest part is as closest to the sternum and between the sternum and the belly button. The next thinnest part is just above the belly button, and then the thickest part is below the belly button. It's comprised of muscle, fascia, adipose tissue, connective tissue, blood vessels, and our sort of lymph as well. In terms of this linea alba, there isn't a consensus really on what normal is in terms of the width within that space. But we've seen that the IRD, the intra, I can't think what the R is, diastasis, so the width, interrectus diastasis, so the width there, is between 0.5 and 2 centimeters, 0.5 centimeters to 2 centimeters. And anything above 3 centimeters above the umbilicus is what we would then maybe describe as abnormal, so that there's a diastasis there. But and it's quite interesting to sort of, even if you haven't had a pregnancy, or if you're a man that hasn't had a change to his abdominal wall necessarily, to actually just have a feel for that central line. So say I haven't had any pregnancies in my lifetime, I haven't had anything that's potentially changed my abdominal wall, and I've got naturally 0.5 centimeters of natural width within that space. So it's really normal to have some width within this space. And I see women in clinic who are very concerned about this width within the linea alba. And actually, for me, that's not necessarily the focus point. We'll go through what the focus points are, but yeah, there's big talk about, yeah, the width, and it's not necessarily, it can be quite a normal phenomenon. The other thing that I would sort of be looking at in the postnatal population is this rib angle. So rib flare, which is a sort of expansion or widening of the ribs, is really common postnatally, and it happens because baby has to grow up into that space, and in doing that, the ribs will flare, and the diaphragm can actually stretch and lengthen by up to about 4 centimeters. And your diaphragm is one of your core muscles, and it's really important for, if your diaphragm is working well, then generally you will have a good connection to the rest of that abdominal wall. But if your diaphragm is being poorly recruited, or you're starting to sort of use your accessory breathing muscles rather than your diaphragm, then there's that potential that the diaphragm is in a suboptimal position, and therefore the recruitment into your abdominal wall is going to be challenged as well. So it's something I would look at to help me understand about, is there then a compromise to the rest of the abdominal wall, and can we think about that as one of the sort of as one of our starting points? Feel free at any point to ask any questions if they're not clear. So what does this abdominal wall provide function for? So it's actually much more complicated or much more important to us than you might think. People might think, well, it just helps us to get out of bed in the mornings because you're sitting up, and that's all it does. But actually it helps with our abdominal and pelvic organ support. These muscles need to work sort of synergistically with all the other muscles in the trunk for optimal function. And intact anatomy is required to facilitate like the sliding of these abdominal muscle layers as well, and to generate force. So a lot of these functions are for this force production, basically. So if you think about if you were to be on an aeroplane, you'd probably do the Valsalva maneuver or movement, which is where you sort of try to close your orifices and reduce or create that sort of reduce that pressure that you're feeling maybe in your ears or in your sinuses. And that's all, you achieve that through this increase in intra-abdominal pressure, which your abdomen has helped you to create. So if you try that now and actually just see if you can sort of unblock your ears, notice what you're doing with your tummy. And it's actually a lot of that tummy control and tummy contraction that helps you to do that maneuver. Yeah.
Oh, sorry, I was going to say, we've got a question about, would you start rehab with diaphragmatic breathing exercises?
Yes, so rehab for diastasis, it's definitely diaphragmatic breathing is one of the first things I would look at. And it can be a really nice way to help that person connect with that muscle, the diaphragm, and also the abdominal wall. We'll go through later about how some women will sort of see diaphragmatic breathing and think that that must be the sort of safest thing to do, and it could potentially understimulate somebody to then not see the changes that they want to be seeing. So yes, it's a really important part of the picture, but it's not the only part of the picture. And sometimes I'll see women in clinic who say, well, I've done all my breathing exercises and I'm not seeing any changes, and it's because they're being underloaded. So it's one small part of the whole presentation. So yeah, it gives you a good idea of how this abdominal wall is really important. So it supports our orifices, it helps us with our breathing, so it assists in that exhalation of a deep breath, and it has to have expansion within it as we inhale. So it needs to be mobile and flexible in both contracting and relaxing as well. It is really important in any elimination of bodily fluids or bowel movements, birthing, vomiting, coughing whenever they happen. And it's an essential part of our general movement. So how we move our head, our neck, our upper extremities and our lower extremities. So looking at the abdominal wall, we're going to go through a little bit of the anatomy. But I know that you all will have some knowledge of this, so I'm not going to go through it too much. But the outermost abdominal muscle is our external oblique, And it's a really important muscle for sort of pulling that chest downwards, compressing the abdominal cavity, and then some of our ipsilateral and contralateral movements. And you can see where it sort of attaches to and then inserts into. So yeah, it's a really important abdominal muscle. If we take that one away, we then come down to our rectus abdominis. You just click on. This is our typical six-pack muscle, and it helps with that sort of bringing the rib cage down towards the pelvis at the front of our abdomen, and then it helps with that sort of taking us into a more of a sort of posterior tilt. Taking that one away, we come down to our internal oblique, which is a really important muscle for our breathing, and it then also creates that rotation and side bending similar to the external oblique as well. And some of the fibers of this one, yeah, just create sort of quite important connections within that linea alba, basically. And then finally, our deepest core muscle is our transversus abdominis. It is really important at sort of creating this corset effect and narrowing our abdomen. And then it's one of the core muscles, so it stabilizes the lumbar spine and pelvis before movement. So it needs to work autonomically or without us thinking about it. And there's often some of that confusion as to when it comes to core activation, whether we should be recruiting that core before we move. And I would say that we shouldn't necessarily be doing that, because the core, and particularly the transverse abdominis, should know that movement is about to happen, and it's part of its natural responsiveness to anticipating movement. And we should always be thinking about trying to maintain and rehabilitate that as much as possible. So if we're then looking at the sort of linea alba itself, we can see that this is the linea alba that runs down here. And as I said, closest to the sternum, you've got your thinnest part of the wall, because this is the linea alba here. You've only really got the external oblique aponeurosis. So an aponeurosis is like that sort of tendon-like structure that isn't inserting into a bone, it's inserting into the central point, which is the linea alba, coming over the top. And then you've got your rectus abdominis muscles coming, the aponeurosis coming underneath. So it's not got loads of tendon-like structures coming into it, because we haven't got the internal oblique and we haven't got the transabs either. As we get down just above the belly button, we now have the introduction of the internal oblique, and that wraps over this sort of rectus abdominis muscle here. So it gets a little bit thicker. And we know that sort of above the belly button, the prevalence of diastasis is 68%. So you're 2/3 more likely, if you've got a diastasis, to have it above the belly button, and your prevalence below the umbilicus is 32%. So you're sort of 1/3 likely to have it below the belly button, because the aponeurosis is so thick. And you can see here that you've then got all of the sort of muscle tendons and aponeurosis connecting and thickening over that rectus, those rectus muscles there. Yeah, so it's a sort of stronger structure, basically. So what is intra-abdominal pressure, and why is it so important when it comes to diastasis? So it's a natural, like we looked at with the functions of the abdominal wall. A lot of the things that the abdominal wall helps us with is to either create intra-abdominal pressure or manage it and reduce it. So it's a really important pressure system in our abdomen that helps maintain essential bodily functions. And you know that from a medicine point of view, in it helping to maintain breathing responses, heart rates, and all of those sorts of things. And it's really our core muscles that help this sort of pressure to stay as it is, or to respond as it needs to. Every movement will create a relative rise in intra-abdominal pressure, some more than others. So did you know that bending at the waist is creates less of a rise of intra-abdominal pressure than sitting does? So sitting is a higher intra-abdominal pressure activity than if you were to stand up and bend at the waist. A bicep curl creates more intra-abdominal pressure than an ab crunch. And if you look at rehab or sort of some of the narrative about diastasis, ab crunches or sit-ups have been demonized and you're made to think that sit-ups could be the worst thing that you could ever do for a diastasis. But actually, doing something to create a bicep curl is harder work for our abdomen and our abdominal wall. Climbing the stairs also creates more of an intra-abdominal rise than an abdominal crunch as well. So if you think about this postnatal population, they're definitely going to be climbing the stairs to go up, if they've got stairs, to go to bed, to put baby down, to go and do loads of washing. And we can make somebody feel really fearful of movement or doing things wrong for their diastasis, but actually some of their everyday functions are going to still be creating this change within that abdominal pressure system. And some of that can be really helpful actually, because it can help stimulate muscles to then learn and get stronger. So yeah, it's just some food for thought for sort of what we're saying are safe loaded exercises. And really with diastasis, one of the big things that I would want you to take away from today is that there is absolutely no do's and don'ts in terms of rehabilitation or safe exercises to be encouraging women to do and to not do, because all of them have, every movement should be possible for women with diastasis, and we shouldn't be putting them into categories which just have no clinical relevance at all. What we need our abdominal wall to do is to respond to these rises with good reaction, good strength, and good endurance. Jumping and weightlifting are probably the things that create the highest change in intra-abdominal pressure. So they are things that we do need to sort of teach that abdominal wall to respond to, but they're sort of always going to be your slightly more end stage rehabilitation progressions anyway. So going back to the doming, so doming, like we said, can either be called doming, coning, tenting, Toblerone shape changes in the abdomen. And it's nothing to fear. It's this response to changes in the pressure system or a change to certain different recruitment patterns. And it can sometimes be thought of as this sign that those muscles have lost that reflexive ability to contract against that rise in pressure. So we know that the transverse abdominis, that deepest muscle that we looked at, should reflexively contract with the other core muscles, the diaphragm, the pelvic floor, and the multifidus, to react and respond to this rise in pressure. And this reflexive ability might reduce if or might not happen if the load is too high for them, or if they've had a change to them, like a surgery or C-section or any other sort of abdominal surgery, where that surgery may sort of put that muscle into a bit of a position where it says, I don't know when or how I should be responding now, because the surgery has inhibited that or changed that. And it might be that actually it's not that, but it's just that that muscle for the desired load is not strong enough to work at that certain load. And we know, like I said, with other muscle strengthening or training principles, that part of how we get a muscle stronger is progressive overload. And so we need to say, okay, it's currently too weak to work at this moment or with this particular exercise, but how do we progressively get it to work at that exercise, which is going to be 3 or 4 times harder? And that will come down to progressive overload over a 6 to 12 week time frame, where that tissue is being stimulated to get stronger. And a study by Lee and Hodges, who are some really good sort of researchers in diastasis, showed that abdominis activation is required to help improve the pressure management within the abdomen. So if there is a sort of poor reflexive response of that transverse abdominis, then it should be just like with the diaphragm. It should be something that should be looked at in those early stages of rehabilitation to help allow that improvement in pressure management. Just conscious of time, but we've got lots of time left, so we're fine. So what with diastasis, a lot of what you might be hearing or what women might be coming to you and saying is, can you, particularly in that sort of 6-week postnatal check, can you check the width of my diastasis or of my tummy? And again, this comes from a narrative which is probably 5 or 10 years outdated, where we thought that a lot of the importance of diastasis recovery was all on the width measurement. But that's not true. And we know that normal ranges within a normal population, so population where they haven't had a change to the abdominal wall, are between 0.5 and 2 centimeters or 50 millimeters to 200 millimeters of width within that space. So my education point to women that are fearful of diastasis or wondering whether that change has happened to their abdomen actually comes to educate them that I'm not all that interested in the width. Yes, I might be interested in width over 3 centimeters, and one of their objectives might be to see if we can reduce that width. But I've seen women who have got 7 centimeters of width and are as strong as they have ever been, and their width hadn't changed with a very progressive strengthening program. But the factors that did improve with that program were the depth and the tension and their function. So to me, those are the more important outcomes to be trying to educate women to focus on. And they're better indicators of how well that whole abdominal wall is working, and particularly that transverse abdominis, and how much strength they're gaining from and through the abdominal muscles. Not just the abdominal muscles, but also all your muscles are going to be connected fascially. So you can actually influence a diastasis with getting strong through your legs, getting strong through your arms, getting strong through your back, because fascially, that improvement in tension in those places has the potential to then improve the fascial connection across your abdominal wall too. So the way that I would measure sort of depth and tension is if you look at the image on the screen, that person is sort of feeling down into that space. The reference point, or the area that will have changed the least during a pregnancy, is the point just below the xiphoid process, so just below the sternum, or the base of the sternum. That is likely the area that's changed the least, and that's your reference point. And your tension there, even though that there has been a change to it, would be 5 out of 5. I would then compare the tension that I'm feeling in that area to then the tension all the way down the linea alba. And if it's feeling, it's very subjective, obviously, but if it's feeling marginally softer, I might say it's a 4. If it's feeling a lot softer, then you're sort of thinking, is that a 1, a 2, or a 0? And it's that tension that you want to be thinking about influencing or improving as that woman goes through the sort of program that was appropriate for their diastasis.
Just got a question, Rosie, about how one was about exercise, and someone read somewhere recently that hard versus soft doming, and that it's okay to continue with exercise if it feels soft, but not if it's hard. Is that true?
That is just the point I was about to come on to.
Oh, there you
go. So you can see that this study by Lowe et al. In 2021 looked at optimal tension. So the doming, if doming is happening in the woman that you're looking at, then like I've said, it's not something to be fearing, but there are presentations of how that dome or how the pressure within that dome is manifesting that may change or or you may want to then adapt the exercise that you've chosen for that person. So if the dome is soft, and if you look at the image on the screen, you can see that that person's fingers are able to push pressure back down into the abdominal cavity. So if there is doming present and you feel the dome, or you get the woman to feel the dome herself, and there is softness to that tissue, then you can imagine that the relative rise of pressure behind that wall is still at a point where it's not so much or so great that that abdominal wall has had to go really rigid to sort of fight it back in, or keep it where, you know, keep it in place, if that makes sense. Hard doming happens when the load within that abdomen has become so great, or the pressure within that abdomen has become so great, that the force is really pushing onto that tissue, and you can no longer like push that sort of dome, or that dome has got no sort of flexibility within it. And we know that this aponeurosis, this linea alba, is very similar to tendons. So the science that we've got from tendon rehabilitation is that a structure is much closer to, or that tendon is much closer to injury or avulsion or rupture when it goes very, very hard. So if we put that science across to our diastasis rehab science, then it may well be that that abdominal wall, that linea alba, is much more likely to create a hernia, which is the risk of that, if that doming is always very hard. So it's a good way to gauge exercise progression. But I would say I'm still very conservative in how I help women with diastasis, but some other physios might think that I'm actually not very conservative. But in my whole time that I've been doing this side of rehab and physiotherapy, I have not felt hard doming. And the other good way to sort of know whether that tension is too much is, are they able to modify that pressure system by continuing to breathe? If somebody is on the brink of that tension being very, very firm, then it's likely that they're holding their breath to create the strength that they need to do that movement, and that will increase that pressure on the abdominal wall as well, and potentially make it feel like that doming is harder or hard doming. So I sort of look at doming tension patterns, but I also look at how they're breathing. So if you can't feel their abdomen, then that's the question you would want to ask is, can you maintain conversation? Can you keep breathing? Can you keep singing? Or could you keep talking to me? Yeah, and then so the other sort of outcome that you might be wanting to monitor is, can strength improve even in the presence of doming, and does your strength improve over time, or does the doming and the presentation of doming improve as you've got stronger? So it's function and doming a little bit, but I've got women who are 10 years postnatal and they're functionally as strong as they need to be, but they still dome in certain positions. And that's really normal, because every muscle is going to have a point at which it's not, there's maybe something that is just a bit not too hard for them, but where that muscle says, okay, I'm not struggling here, but everything else is managing, if that makes sense. But again, that doming is not unsafe, but they don't see doming for 99% of the work that they're doing, and they see doming for 1%, but it's not hard doming, they're still able to breathe, and that's perfectly fine for that to be happening. Yeah, Lily, have you got a question?
There was another question around, how would you measure depth?
Depth is measured, so again, like the image on the screen, you can measure width by popping your fingers into the width side by side. And for me, I know because I've measured them that 2 of my fingers side by side is 3 centimeters. 1 is 1.5. 3 fingers for me is 5 centimeters. So you can measure your fingers or do a finger measurement and then measure it when the patient's not in the room. Depth, you want to see how far your fingers are being pushed into that space. So for me, again, I know that if it goes up to my top of my fingernail, so the sort of white part of the quick of the fingernail, then that's about 1 centimetre. If it's going to my first knuckle, that's about 2 centimetres. And if my fingers are sinking in and the line of the abdominal wall, so with this image, I would probably say that's about 3 to 4 centimetres of depth within that space. And the depth is the more important factor over width because it's showing you how almost, I hate this word, but how almost saggy that tissue is. So how much is it wanting to sink in? Because then at rest or when that person isn't under tension, and I always measure diastasis under tension. So when that person has lifted their head off the bed and done a sort of abdominal crunch, it's repeatable, so you know that you're going to do it every time that you're reassessing it, and it's also more functional. So you can measure it at rest, but I think it's a more important measurement under load. So the depth, as that person and as that tissue gets stronger, potentially thicker, which is what happens when we get stronger, and the thickness may increase and improve the tension. It's likely that the depth will then shallow. So the more shallow that tissue is, the less that sagginess is wanting to dip in, and the better you're creating that tone and tension across the abdominal wall. Sometimes, if depth is reducing, then your width may increase. So if you think if it's, I don't know if you can see this, but this structure here, and these are your 2 rectus abdominis there, you might get this sort of sagging in and you've got a little bit of depth in that tissue there. But as you get stronger, you can see that if we then create that, reduce that width, actually my 2 thumbs get further apart. So I don't really mind if the depth is improving, that the width may be worsening. And that's exactly why you shouldn't be focusing on the width as much, because it's not necessarily the best indicator for overall strength and tone and function of that abdominal wall. Hopefully that makes sense. Other things that you could encourage somebody to measure or measure yourself, and these are sometimes harder to do, is the circumference of the abdominal wall. So taking a measurement around the belly button or at the level of the belly button, sorry, because it's then repeatable, and seeing if that the muscles are then creating better tone and reducing the circumference size. Posture, is there an improvement in those muscles to improve postural, good postural alignment? Are they getting stronger? And the final one, which you've got to be a little bit sensitive to, and is taking pictures. It can help motivate, it can encourage a slight obsession with it, and it's not always the right thing to do, but sometimes I do encourage women to take a front-on image and a side-on image, and I then say that I can analyze it, because you can start seeing sort of muscle definition or reduces in or improvement in tone with that. I'm just conscious of time. I don't want to run over, and I want to give time for some questions at the end as well. So some of the basics is the person. So who are they? What are their what's their story? What's their expectations for this? What is their baseline level of function and strength? Now I'm starting to rush, which I shouldn't do. Posture is the interecti distance wider in an upright position, and is that changing their postural alignment? The sort of head position, which again you can photograph, is that which in the sort of forward head position increased activities of the scalenes, and the sternocleidomastoid muscles, and decreased forced vital capacity. So it had a big change in their breathing function. What are their holding patterns like? This is a big one to look at in terms of diastasis. Is that person trying to really grip with their tummy all the time, either because they're conscious of changes and aesthetic changes within the abdominal wall, or they're really weak actually, and they're trying to create as much tone and structure within that abdominal wall as they possibly can. What is their recruitment pattern like? What does the abdominal wall do when you breathe, when you engage your transverse abdominis, if you can isolate it, when you engage your pelvic floor? And yeah, is there any sort of pelvic floor pattern or dysfunction at play as well? And is that impacting the function of the abdominal wall? The two aren't necessarily linked, but it could be that there's a general weakening of all of the systems and structures within that area too. What are they breathing like? What is their breathing like at rest? Have they got any sort of like changes or breath holding patterns when they're moving? What is their rib cage angle like? Is there symmetry? Is there any flare? What's that sort of infrasternal angle like? Have they got any thoracic mobility issues that could be compromising the progression or their ability to move in that area? What happens when they're being loaded? So transferring load, they're stabilizing, or sort of managing pressure when load increases. It's a really important part of how we look at diastasis management, because mechanical loading is one of the strongest stimuli to adaptation of matrix tissue, which this all is, and of tissue healing as well. So structures need to be loaded to actually optimize the healing response, but it needs to be safe and progressive for the abdominal wall, and it needs to be individualized. So Pilates plans, core restore programs are all great as they get this sort of the person moving, and stimulus is likely to sort of encourage them to sort of address this issue. But you may find that that person that's done a online Pilates postnatal program is maybe being understimulated or underloaded, and they then need to have a bit more of an individualized approach. So load is very individual, if that makes sense. And is there a defect? So is there a hernia presentation, or is there an abdominal protrusion presentation where there's that whole abdominal wall sort of weakness? So some of the conservative management of diastasis basics is get them moving, get them mobilizing. It's all really important, yeah, for general function, and the ability to get stronger comes down to often mobility and range of motion. What are they breathing like? Has the pelvic floor been considered? As I said, it's not always the first thing I would think of in terms of diastasis, but it's part of the picture. What's their transabs recruitment like? And you can see that when they're just being loaded, is that reflexively coming on or not? What are their functional movements like, and what are their defecation habits like as well? Are they straining when they're on the loo and creating that abdominal wall to sort of have a continual or progressive rise in pressure? There's a big media focus on diastasis, and which is really great because it's helped to highlight that these are issues with you know, within women's health. But are we making something that's essentially a normal process into a health problem? You need to get the basics right, and that person's question on would you start with breathing? Absolutely, but don't stay at breathing. It has to be a structure that's then loaded and improved in how it's being challenged. Fascial networks help that tension of that aponeurosis. So getting globally strong is actually a really good way to focus in terms of diastasis, but don't stop there. Consider loading and monitoring that progress as well. So yeah, as I said, one of this mechanical loading is one of the strongest stimuli to adaptation of matrix tissue, which this is, and tissue healing. So we need to be loading. There may be changes in that collagen in that midline, which may well limit somebody's progression with diastasis. So it needs to be considered in terms of it, first of all, presenting, but also that person's ability to continue getting stronger. Education is so important, and it's something that you, as the sort of first person this person might be talking to about diastasis, can help with, because it can really reduce fear and assist that sort of understanding of what's going on. And then have that repeated measure. So it takes a long time to potentially create changes for diastasis. You know, it can take 12 to 18 months really to see that consistency with progressive overload. So don't sort of just expect them to see results within 6 weeks, because it may be too little time. Yeah, we've sort of slightly gone through this. The balloon analogy is that that person can maintain breathing whilst they're in a loaded position. So sometimes I get women to imagine, or actually I have got balloons in my clinic, to be able to blow up a balloon in a loaded position. So if you can't, then your potential for that sort of load through the abdominal wall is higher, and that exercise may not be the right one for you. So you should be able to blow up a balloon in any loaded exercise that you're doing. Think about different positions. So all exercise should not be done on your back or on all fours. You can do lots in standing, you can do lots bent over, you can do lots of other positions as well. So yeah, change it up and be varied with your rehab approach. And rotation is actually really important. It's really good for those obliques, and that can really help to create that sort of diagonal connection across that abdomen to help that tissue to heal and repair. There's an American physio that says blow as you go, and that's really a nice way to think of that management of breath for our diastasis. Don't be afraid of the doming. Challenge that optimal load position. Use weights, reps, and positions to challenge that, how that person's being loaded. And biofeedback is really useful. So thinking about like mirrors, or can they see their abdomen moving, particularly in that stage where they may have a disconnect from that transversus abdominis and it naturally pulling in post C-section recoveries and things like that. Are we all right for time, Lily? I'm just conscious that we're now at the hour. I'll probably be another two.
Yeah, no,
right?
just continue. That's absolutely fine. And then there's some questions that have come in, but we'll ask them at the end.
Okay, perfect.
Yeah, just continue. That's fine.
So what happens when they're not progressing? So go back to the basics potentially. Have they skipped that part, and then they're exposing themselves to unnecessary intra-abdominal pressure when they could be managing it better, and that's then not helping their progression. Is that matrix of tissue getting enough stimuli? So particularly with like at home or people that are maybe needing a bit more response, do they need to be thinking about gym memberships or getting a little bit more through that tissue? And at home stuff is more than enough often, but yeah, you might just want to think about how else can you stimulate that tissue. Are you focusing on the wrong outcome measures? So if your client's really focused on the width, is that the right thing? And can you help educate them on actually it's not a outcome measure that's actually that important, and the depth and the tension are the ones to really focus on? And have you given it enough time? So you do need to give this time. You know, I would never consider any other discussion outside of rehab until they've done 12 to 18 months worth of consistent, and it's often the consistency which is key, rehab, to just try and see if they can stimulate the changes through there. So functional diastasis is definitely a term that I am using and applying to women more and more. It's when there's still that palpable gap across the interrectus distance, but the depth and the tension are optimal, they're fine, and the linear alba can respond to that increase in intra-abdominal pressure with no conscious stimuli. So they're not having to always think about cueing or their core connection or pelvic floors, whatever might have previously helped manage that tone and that intra-abdominal pressure. So I see lots of women who are sort of 2-3 years down the line, they still notice maybe aesthetic changes to their abdomen. They still potentially notice doming. I work with a lot of CrossFit athletes when they're doing rope climbs or kipping or even like double unders, but they're as strong as they ever have been, and that diastasis is still soft when it does dome, and it has no bearing on their function. And sometimes it comes down to that conversation of saying, okay, you have done everything you can possibly do, but you have had some things or a pregnancy that has changed this function of the abdominal wall, or not the function, the appearance of the abdominal wall and the sort of slight laxity within there, but you've got enough strength there to manage all of that. So a lot of discussion about belly binds. It's something that actually is used a lot in Australia, but I would say that they shouldn't be recommended as a first-line treatment, and should just be really for very specific cases of diastasis, and that would be any abdomens that are painful or where they really improve their function because of the belly bind in those sort of first few weeks or months postnatally. They can help with comfort and they can help with that sort of feeling of that connection to that tummy, but we then have to think about them weaning off it, and there isn't any evidence really for the benefits of them. Surgical management is another question that I get asked a lot, and so sometimes conservative management doesn't do everything, but it's very, very rare that you need surgical management of diastasis because of a functional need. So if somebody is sort of saying, I really feel like, I'm not as strong as I can be, I've tried everything. Have they tried everything? Has that conservative management been fully explored and for long enough? And often surgery is more of a cosmetic need rather than a functional need. I've had women who have had, one woman recently who had 11 centimeters of width within her linea alba when she went in for an abdominoplasty, but she was functionally stronger than she had ever been, and she knew that she wasn't going through the surgery because she needed it for her long-term health or her strength in the moment. It was because she was unhappy with the appearance of her abdomen. So it's something not to take lightly. It's a very considered and considerable surgery. And unfortunately, there isn't a standardized pre and postnatal op protocol. So, some women who can't afford to then see a physio privately may just be left high and dry with a huge amount of rehab that's needed. One of the big things with surgery is actually swelling management. And that can be really helped with returning to movement and understanding why that swelling is happening. But there isn't this sort of standardized protocol that we might see with hips and knee operations and such. There are Claire Black is a Scottish lawyer who actually had a very considerable diastasis, which she has actually now had repaired. And she's got an Instagram page, which is very interesting to follow. And sometimes I send some women there because from a diastasis point of view, but also a surgery point of view, because she really rehabbed incredibly well before her surgery, and her surgery wasn't needed, but she was back and she'd actually started CrossFit with a diastasis and got much stronger than she had ever been before her diastasis or before her children. And then Lisa Ryan is an American who's got a very similar story as well. So what about you and your practice? Education, education, education for you, but also for the patients. The more educated they can be, generally the better, and the less fear that they might have with movement and with their bodies. Remember, it's a very normal presentation in the third trimester. It happens in 100% of women, and generally 8 weeks postnatally, there will still be a degree of separation within that wall. So I generally wouldn't assess it until 6 to 8 weeks postnatally, when you've given it as much natural recoiling time to see where it's at. Fear of movement can sometimes inhibit somebody to be making progress. So reducing fear is really important. And then building that strength and integrity of that abdominal wall is important for movement, but also bodily functions as well. And adequate strength within that wall could help reduce risk of potentially pelvic floor dysfunction and or hernia presentation as well, because that wall is just being taught how to manage rises in intra-abdominal load better. And then if you're suspecting a diastasis, or you feel like somebody would benefit from some more specific insight into it, then referring to a pelvic health physio or a trained personal trainer can really help at any stage as well. And that's any stage postnatally. It doesn't have to be in those first few weeks. Yeah. Any questions at all? Sorry that I ran over, and I see that some people have had to leave, but yeah, happy to stay around and answer some questions.
That's brilliant. Thank you, Rosie. I don't know if those who posed some questions in the chat box want to ask them themselves, if they're able to.
Hello,
I think
Rosie.
you first, Ren.
Oh,
Hi.
hello, Rosie. Thank you so much. It's so needed, to be honest, this presentation. Really helpful. Thank you. I work as an FCP in a GP practice. Would you recommend any exercise sheet or patient advice link or anything we can give out as an FCPs to patients?
The two sort of resources that I often send people to are either Granier Donnelly, and these are both in the slides which Roger and Lily have, so they'll be able to forward that over to you. And so all of my references are on the slides. But Granier Donnelly, who's an Irish physio, is sort of a specialist in it, and she's very, very good. And she's got some really useful tools on her website, which I'll link to with Lily's after the presentation today. And then Munira Hudani, who's a Canadian physio, is also sort of a leading expert in this area. So they have both got some good resources to look at. And normally the sort of physio body, CSP, but our sort of more specific one, that the POGP has got some leaflets on there, which will definitely be sort of quite NHS specific, if that makes sense. So I'll try and find that one and send it over to you. But I think like it's important that like education is there, but remember it's always that individualized approach. So the most important thing is any exercise could be a really useful strengthening tool for that person, and somebody might not be progressing on a specific do these exercises type of approach. So it's caveating it with that, I suppose. And if they're not progressing, then maybe seeing one of the pelvic health physios in your team to see if there's anything more specific they could do.
Thank you. There's another part of my question.
Yeah.
Thank you. In BNSSG, we do use the My Joint Health Hub link, and there are some advice and exercises about postnatal recovery. Is that the right place to look, do you think? The My Joint Health Hub. Have you come across?
I don't know it, but yeah, I'm sure that there might be some things on there, but yeah, because I'm not in the NHS, I'm not familiar with it, I'm afraid, so I'm not sure.
Thank you.
I'll just ask Mengu's question because she hasn't got a mic. Is it harder to recover if nothing has been done for the 10 to 20 years? So there's really delayed presentations that come to you. They're not delayed presentations, those ones are delayed and actually doing anything about it.
No, so muscles can be stimulated at any stage in life. So yeah, there's no harm in trying to encourage and go back to all these things at any stage. And yeah, it may well be that somebody who is 10 to 20 years postnatal has never had their breathing looked at, has never had that look at how are they loading their abdominal wall? Are they progressively strengthening that abdominal wall? So it's never too late. Yeah, but it's likely that that person has potentially created functional tone across their abdominal wall because they've gone about their daily lives. But you could still influence the depth and the tension and potentially the width of the diastasis, yeah, even that late on.
Perfect, thank you. And Alison? Oh, she's disappeared off. There was she was asked. Oh, there you go.
I think you're on mute.
I was just wondering about information for men, because obviously it is fairly easy to find information post-pregnancy, but not for men who have similar problems. And obviously I do understand that sort of specific rehab thing, but have you got any sort of references that we could supply to blokes, really?
Yeah, it's hard because a lot of it is pregnancy related, but all the principles stay the same. And I suppose it's just yeah, again, Munira Hudani and Grania Donnelly, if they can sort of decipher that, I think they are pretty women specific, though their sort of websites, but yeah, it's sort of pulling out the information that's appropriate for them and trying not to look at it as too much of a woman's problem.
Warn them that it's going to be very pregnancy related, but it applies the same. But I just wonder whether you had anything specific. Okay, thanks.
Yeah, I'll have a look, but I can't think of any.
Lovely, thank you.
Perfect. Does anybody else have any questions? No? Brilliant. Thank you very much. I will stop the recording. We'll do that. Thank you everybody for